second day of the 7th International Thoracic Oncology Symposium. Due to ongoing pandemic, this edition will be the first online edition. We are afraid that you could not join us here in Milan for a couple of days. However, I think that this edition will be a fantastic learning experience as well. The symposium will provide a comprehensive update on the treatment of thoracic malignancy with special emphasis on the multimodality treatment. So we decided to split the program into main parts. Yesterday, we approached early disease, and today we will approach advanced disease. Yesterday, we did very well with many connections, and I'm glad to communicate that we had about 70,000 viewers worldwide. So very good numbers. Now, I'm honored to introduce Dr. Diego Cortinovis, oncologist from our hospital here in Monza, who will lead you during all the sessions today.
Okay. Thank you, Federico, and thank you all the speakers and the participants to this second day. The presentations of Lung Cancer European meeting is insight to a thoracic oncology symposium. And the meaning of this strange edition is due that the words amongst thoracic surgeons and medical oncologists put together in order to improve the treatment of lung cancer and thoracic neoplasm. So it's very important for me in particular to thanks a lot Marco Scacci and Federico Raveglia, all the sponsors that sustain this second day, and that give me also the opportunity to share many information and new information about lung cancer. In particular, in this second day, we try to divide our day in three main sessions. In the first session, we try to provide some information about immunotherapy and in the oncogene addicted world, in particular in neoadjuvant setting. In the second session, we started to talk about the rarest disease in lung cancer field, in the oncogene addicted world, and obviously also some orphan disease like small cell lung cancer. So we don't forget also the activity of surgery in the early disease, and we would like also to integrate all this information about radiotherapy, surgery, and chemoimmunotherapy in the first part of the patient journey. And the third and last session at the end, we try also to understand some new compelling evidence in unresectable stage 3 lung cancer, and also with some changes, the activity of surgery in this kind of disease. At the end, we try again to recap some information about mesothelioma and small cell lung cancer. So I would like also I believe that this second day will be very interesting for all the participants. And I thank you again, all the panelists that are very important around the world, in order also to share some ideas probably that are different in the many and different countries. So I would like to start, if there are not other information of technical information about this day, with the first session. So just to remember that to unmute all the non-speakers, and we have also the possibility to have a chat and the live chat in order to exchange some comments or also some questions from the audience. Is a sort of really interactive module. So I would like also to stimulate all the panelists and also the audience to give some insight about or comments about all the presentation. I try to collect during the speaking session all this information, and try also to distribute some comments or a burning question to some speakers. So I would like to start with the first session, And I would like also to invite the first speaker that is my really very friends, is Matteo Giailevra, is an assistant specialist of oncology and thoracic oncology and services in Grenoble, France. So the first topic is about the immunotherapy in resectable non-small cell lung cancer. It's a topic very, very important and challenging in after years in this setting of disease. So Matteo, if you wanted to start with your talk.
Good afternoon. First of all, thank you very much, Diego, for your kind presentation. I'm Matteo Giailevra from the University Hospital of Grenoble. And first of all, I would like to thank the scientific committee for inviting me to discuss about the role of immunotherapy in resectable non-small cell lung cancer. These are my disclosure. So in the next minute, we will discuss about the rationale of neoadjuvant treatment and neoadjuvant immunotherapy in oncology, and especially in non-small cell lung cancer, looking at the preclinical clinical results that we obtain in this particular setting. Then we will discuss about the primary endpoint that we can use in this kind of trial, and which is today the best primary endpoint to use. And to conclude, we will have a small discussion about biomarkers in this setting and which are the challenges for the future. So which is the rationale for neoadjuvant treatment? We know that chemotherapy may rapidly shrink the tumor size, and so that can limit the extent of surgery in order to achieve a good resection. At the meantime, we can treat micrometastatic disease, and we know that more patients are able to receive a neoadjuvant treatment instead of an adjuvant chemotherapy. And we know also that neoadjuvant approach can give us the opportunity to study the pathological evaluation of our systemic treatment on the patients. But we have also some disadvantages. We know that sometimes we have a delay of our surgery. We have a risk of progression of disease during chemotherapy or during immunotherapy prior to surgery. We know that until now, surgery is the only curative treatment that we can use for our patient, and so it could be a pity to risk a progression prior to surgery. We can have some potential surgical complication, so we can have fibrosis, necrosis that can have a problem. And for some patients, a neoadjuvant treatment could be a potential overtreatment. We know that there is a role of surgery and immunosuppression. Surgical debulking initiates inflammatory, neuroendocrine, and metabolic events, which resulted in an altered cytokine level. We have a decrease in interleukin 2, 12, interferon gamma. We have an increase in interleukin 6, 10, and tumor necrosis factor alpha. And we have the release of some growth factor like VGF, PDGF, transforming growth beta factor beta, clotting factor, and stress hormone. This event lead to the expansion of Tregs, MDSC, and 2 macrophages. And the increase of these regulatory immunocells lead to an augmented expression of PD-1 and CTL4, a decrease in T cell proliferation, and impaired natural killer cell cytotoxicity, resulting in an overall state of immunosuppression. We have seen before the rationale for an adjuvant treatment in general. Which are the rationale for an adjuvant immunotherapy? We have the same benefit that we have previously seen with chemotherapy, but at the same time, in our specimen tumor, we have the possibility to study the microenvironment, the change in the microenvironment after immunotherapy and the role of PD-1 in this setting, and the presence of tumor antigen presented in the tumor presented before the resection can have a stronger and prolonged anti-tumor T-cell immunoresponse. Which is the rationale for an adjuvant immunotherapy treatment? So, following the administration of immunotherapy, tumor-specific CD8 T-cell can undergo tumor expansion, and this T-cell can kill existing tumor and recirculate into the blood. In addition to this mechanism, the existing of specific tumor T-cell response can result in a relapse of new antigen that are presented to the antigen-presenting cell to prime naive T-cell with a tumor specificity against our tumor cell. After surgery, the remaining circulating tumor-specific CD8 T-cell and those presenting the metastatic site have an increased T-cell tumor ratio, which is likely to provide an advantage in the destruction of remaining tissue. We have preclinical study that show the role of neoadjuvant immunotherapy in non-small cell lung cancer. In this abstract presented by Cascone in 2018, we see that single agent and combined immunotherapy significantly prolonged survival compared to control arms in both neoadjuvant and adjuvant groups. If we combine therapy, we have a superior efficacy in terms of survival, and especially in the combination of anti-PD-1 and anti-CTLA-4 compared in the adjuvant setting compared to patient treated in the adjuvant one. Looking at the role of neoadjuvant treatment in the treatment of micrometastases, we can see that both monotherapy and combined immunotherapy have a major role in the reduction of the metastatic site in the neoadjuvant setting compared to the adjuvant one. So these data can support the role of neoadjuvant immunotherapy compared to adjuvant one. And so in the last 2 years, we have many clinical trials, especially phase 1 and 2 with small sample size, that try to test the role of immunotherapy alone or in combination in stage 1 and 3 non-small cell lung cancer. As you can see, the primary endpoints are extremely heterogeneous, with major pathological response are the most used primary endpoint. And if we look at the major pathological response, we can see that they are extremely heterogeneous. We have a range that came from 19 to 45%. And if you are looking to the complete pathological response, we have a fewer percentage of success, and we have entre 0 and 29% of complete pathological response. At the same time, we have a neoadjuvant chemo-IO trial that have been developed. So we have the association of chemotherapy and immunotherapy. We have also here an heterogeneous number and primary endpoint that were used, but it's strongly interesting to see how the major pathological response is higher in clinical trial. They will use a combo of chemo-IO, and we have also a higher percentage of complete pathological response with a range of, we have also 60% of complete pathological response in a DADIM trial. So this data suggests that the combination of chemo-IO could give us a major pathological response compared to IO alone. Looking at the primary endpoint that we can use for neoadjuvant therapy, it's sure that overall survival should be the gold standard. But unfortunately, is unacceptable to use because we have a long delay. We are in a curative setting, and so before obtaining overall survival, we have to wait many years, and so it's not acceptable for a clinical trial. So we are looking for a surrogate endpoint, and so could be disease-free survival a surrogate endpoint for overall survival. There are some concern about this endpoint in early stage non-small cell lung cancer, and so there are some discussion about its role, and it's clear that overall response rate is a poor predictor of time to event as an outcome like overall survival, and we cannot use overall response rate as a surrogate of overall survival in non-small cell lung cancer. As we have previously seen, major pathological response is the most used primary endpoint in neoadjuvant chemotherapy immunotherapy trial. We define a major pathological response as less than 10 or equal of 10% of viable tumor cell. This endpoint have been tested and approved in neoadjuvant chemotherapy and chemo-VEGF, anti-VEGF treatment in lung cancer trial, but we do not have many information about its role in immunotherapy trial. Recently, Marie Bislez presented the ESMO trial, the results of the French intergroup neoadjuvant immunotherapy trial with durvalumab in patients with stage 1 and 3 non-small cell lung cancer. The study was interrupted due to the toxicity after surgery. And as you can see, the authors tried to see if there is a role of major pathological response and overall survival. And here we can see there was no statistical difference between the patient with a major and not a major pathological response. This difference was seen in disease-free survival. We know also, I'm not pathologist, but we know from a pathological point of view that they are different in the tumor specimen for patient treated with chemotherapy and patient treatment with immunotherapy. In patient treatment with immunotherapy, we can have a tumor infiltrating lymphocyte, cholesterol cleft, neovascularization, and proliferative fibrosis that have never been described in patient treated with chemotherapy. For that reason, as we are not used in daily practice, but as we have immunorelated RECIST criteria, on the same way, Cottrell presented in 2018 a proposal for an immunorelated pathologic response criteria. So they changed our idea of criteria of pathologic response adapted to immunotherapy trial. Until now, we do not have a clinical trial that tested this pathologic response criterion. We have the PRINCEPS trial that have been presented at the ESMO by Benjamin Bates, who use as major pathological response this immunorelated criteria. Can we have a biomarker that can give us an idea about the major pathological prediction of major pathological response? It's interesting to study the role of PD-L1. We have 3 clinical trials that demonstrated the role of PD-L1 expression as a predictive marker of major pathological response. We have the LCMC trial, the NeoSTAR trial, and the PRINCEPS one, who show a stronger correlation between PD-L1 and pathological response. Why in the 4 that all, we don't have a significant correlation, but we have a numerically differences between major and non-major pathological response. So, like in metastatic non-small cell lung cancer, we can see that PD-L1 can predict major pathological response, but we have also patients with negative PD-L1 who can respond with neoadjuvant immunotherapy. The role of TMB is under discussion because we do not have many data about the role of TMB as a predictive role of major pathological response. Here we have the results of the LCMC trial, which do not demonstrate a difference in terms of pathological response according to the TMB. For that all have a small sample size of patients, yes, we have a statistically different between the 2 groups, but in the patient with major pathological response, we have only 3 patients with a high TMB. So numerically, it's not possible to define its role until now. Really interesting could be the role of ctDNA. Here we can see the results of the 4th clinical trial of neoadjuvant nivolumab in early stage operable non-small cell lung cancer. For this patient, the therapeutic effect was measured by pathologic assessment of residual tumor after 2 doses of immunotherapy. And the author observed that all tumor with a major or partial response to anti-PD-1 therapy demonstrated a molecular response pattern of elimination of tumor-specific mutation in the blood. In contrast, tumor without a pathologic response demonstrated a molecular resistant pattern at the time of resection. So this is a concept of molecular residual disease in which some protocols, some clinical trials are exploring the role of ctDNA in order to study their role in neoadjuvant setting. Which are the perspectives and the challenges for the future? It's sure that as we have seen previously in stage 4 and stage 3, the interesting is to study the role of IO and chemo-IO in early stage or locally advanced disease. So there are many clinical trials that are investigated immunotherapy alone, immunotherapy associated with target therapy, or immunotherapy associated with chemotherapy. Most of them are phase 3 clinical trial. And so it would be interesting, exciting in the next future to see these results. Which are the perspective and the challenges of the future? It's sure that as is for metastatic setting, also for neoadjuvant setting, there are some challenges. For example, the surgery approach, what we have to do, we know that in some cases, patient treated with immunotherapy can have some problem during the surgical approach, which is the role, and we will see later, of oncogene-addicted tumor in early stage disease, which is the role of adjuvant immunotherapy after neoadjuvant immuno-1, which are the good predictive biomarker that we can use in a routine, and in case of progression of our patient after disease, after surgery, there is a role of rechallenge with immunotherapy in a patient previously treated with this kind of drugs. So, in conclusion, we see that neoadjuvant IO and the combination chemo-IO has shown encouraging results in this setting. Major pathological response are elevated when IO is combined with chemotherapy or other IO other than immunotherapy alone. It's clear that we have to define the role of major pathological response and if it's the good endpoint in this setting. And we need research to identify the potential biomarker for personalizing neoadjuvant treatment approaches. Thank you for your attention.
Okay, Matteo. Thank you very much for your brilliant presentation. We have probably sometimes also to have some question from the audience. Otherwise, I would like to start just one comment about the employment of immunotherapy in resectable non-small cell lung cancer. In your opinion, Matteo, in the near future, we started to treat all the resectable patients with immunotherapy or chemoimmunotherapy. I mean, we started to propose to our patients from the stage 1B this kind of treatment.
Thank you for your question, Diego. I'm not sure that all the patients will be treated with IO or chemo-IO also in the adjuvant setting. I think that early stage non-small cell lung cancer could be treated with surgery up front. My concern is about the risk of hyperprogression, of progression disease during treatment. We know that we have this risk of progression under immunotherapy. So until we have not the possibility to identify a predictive biomarker for have a success in the treatment in the use of neoadjuvant chemo-IO, I think that until now we are not able to prescribe this to all our patients.
Okay. So I don't know if there are some surgeons online. I think yes, because I saw also some message from Dr. D'Amico. What is from a surgical point of view, the difficulties to treat these patients after the exposure to immunotherapy? I mean, in the NeoStar trial, for example, a survey that are administered to the surgeons give some perspective about more difficulties to do a surgical approach after immunotherapy. If some surgeons would like to expose maybe some direct experience about surgical approach after immunotherapy, it will be my pleasure also to share this experience. I don't know if Dr. D'Amico or Dr. Costas has this experience.
I would be able to comment if you would like me to.
Okay.
Sure. So it's different. I wouldn't consider it more difficult. I think it's similar to chemotherapy. The more cancer there is preoperatively, the more immunotherapy interacts with the local environment of the tumor, and the more difficult it may be. Immunotherapy alone is not, I don't think, is more difficult than chemotherapy. The difference is that chemotherapy will make cancerous nodes smaller. Immunotherapy will make cancerous nodes bigger. The cancer will get smaller, but there's a lot of inflammation around the lymph nodes, which can complicate the surgery, especially if it's a planned right pneumonectomy or a planned left upper lobectomy, because of the location of the lymph nodes and how it changes the context of the operation. So I would call it different, but not more difficult.
Okay. So are you ready today to accept immunotherapy as a good therapeutic option for our patients from the early stages or not?
I think it should be used in every single patient.
Fantastic. So thank you so much for this perspective, because it's are really important for us. And I don't know, Dr. D'Amico asked Matteo if there are some differences between IO agents in the induction setting. If you wanted to reply briefly.
At the moment, we do not have any data that demonstrate difference between anti-PD-L1 and anti-PD-L1. I think that we have to wait the phase 3 trial that are ongoing in order to see if there is some differences, as we have previously seen for higher PD-L1 and pembrolizumab, but until now there is no differences.
But the different companies have, there's no incentive for them to compare themselves in a trial.
Yeah.
You know,
no, we will not be able to compare directly.
Right. There's not going to be a Pembro versus Darva trial, which is what eventually we need to know that, unless it's proved that they're all the same and it doesn't matter which one you use. But I don't see them supporting a trial that compares their agents, because one of them will lose, maybe.
Exactly. No, I totally agree.
Okay, a last burning question is about the timing between immunotherapy and surgery, if there are any perspective about that. What is the optimal time to surgery after the neoadjuvant immunotherapy?
So if it's IO only, then it can be 2 weeks.
Okay.
If it's IO and chemo, it's the same as chemo, 4 or 5, depending on the patient's performance status and recovery, and that's individualized. But to me, I would rather operate too late than too soon.
Okay.
You can always get the tumor out. You can't make a debilitated patient more strong the day after surgery.
And Matteo, there are some recommendations about the neoadjuvant chemoimmunotherapy in preoperatory setting instead of immunotherapy alone.
In terms of toxicity, in terms of
we don't know, because we haven't any indication today to this approach.
In our center, we have some clinical trial with neoadjuvant chemo IO. So we treated 2 patients with early stage, and we didn't have, luckily, we didn't see any toxicity, and we didn't have any delay in surgery, any loss of opportunity. It was interesting that 1 patient, before performing surgery, have to have had a CT PET scan as provided by the protocol, and all the mediastinal lymph node was active at CT PET scan. We decided to perform surgery, and there was negative lymph nodes. So there was an activation of this lymph node due to the immunotherapy.
Okay. Thank you so much. And we leave now to this presentation. And I would like to invite the Dr. Nir Peled to join us. And Dr. Nir Peled is the chief of a medical oncology unit in Soroka Cancer Center, Ben Gurion University, Beersheba, Israel. It's a pleasure to introduce your talk about the news in immunotherapy world in advanced non-small cell lung cancer, if the bar is really improving or not. Thank you.
Hello, my name is Professor Nir Peled from Soroka Medical Center, Ben Gurion University, Israel. Those are my disclosures. Before we go into the details, I would like to go with you over the top breakthroughs in lung cancer. Among them, the reduction of lung cancer-related mortality by low-dose CAT scan screening, the ability to predict response based on genetic and proteomic biomarkers, the evidence of high efficacy of driver-related treatment beyond the EGFR, ALK, and ROS1, the PD-1, PD-L1 incorporation into the first and the second line therapy, as well as post-chemo RT, the anti-PD-L1 antibodies in the first line extensive small cell lung cancer, both Atezo and Durva data. There is great breakthroughs in penetrating the brain with alectinib, tagrisib, brigatinib, and other TKIs. we can overcome today the resistance to tyrosine kinase inhibitors by uncovering them, as well as profiling the disease by circulating free DNA that we may perform in different time spots. There are several lessons in immunotherapy of lung cancer, among them the evidence of pembrolizumab for PD-L1 strongly positive patients in first line, the chemo-IO combination in first-line therapy, the second-line therapy approval for pembro, nivo, or atezo. As was mentioned previously, the durvalumab in the consolidational phase of post-chemo T have shown a significant disease-free survival. The evidence of PD-L1 blocker in extensive small cell lung cancer has been very well established. We have learned today that we do have a limited efficacy of immunotherapy in patients with classical driver mutations. We have also learned that there is a similar toxicity among PD-1 and PD-L1 related therapies. We know today that PD-L1, tumoral mutational burden, and MSI are all very good predictors for response to IO, and we have also learned that IO combination do have a better response rate and PFS compared to immunotherapy single agent therapies. Multiple targets are available in adenocarcinoma mainly, and as you see in this slide, there are numerous options for therapy for every one of them. Some of them have been approved and still some. When we focus on the NCCN guidelines, we may see also that many of those biomarkers are directing treatment. However, we should also ask ourselves, all those biomarkers should exclude patients for being treated by immunotherapy because data of a comparison arm for MET-exon 14, BRAF, RET fusions are not available at this point. PD-L1 is a very strong predictor for response to IO, as TMB. The higher TMB we may see a better PFS in immunotherapy that have been approved in the CheckMate, but also in other studies. And definitely TMB is a very good biomarker. Likewise, we may see that PD-L1 staining should be act as a biomarker, because if we focus on the PD-L1 above 50% in the Keynote 24, we can see that the 5 years overall survival for patients with PD-L1 above 50% is 41% in the 42 months follow-up time. The positive studies that have been approved for first-line therapy in non-small cell lung cancer are summarized in this slide. And as you may see that we do have many options for all those patients, either pembro alone for those patients with PD-L1 above 50% or different drug combinations. If it is pembro-based for adeno or squamous, or atezo-based for adeno and squamous, with a different range of hazard ratio and median overall survival around 17 to 22 months in the pembro studies, and around 19 months for the atezo in the different combinations. The CheckMate 227 will be discussed later, and it has shown us some benefit for some patients that can be treated by IO compared to chemo-IO combination. The ESMO guidelines, some split actually. There's guidelines upon the PD-L1 staining. Patients with high PD-L1 can be treated by pembro or atezo, while chemo-IO is also an option. For squam, similar, and for those patients with PD-L1 below 50%, the split is mainly focusing on combination of chemo-IO or some patients with IO. The recent ESMO brought us few updates associated with immunotherapy in lung cancer, mainly Nivo-Ipi combination, either by 9LA combination, which means chemo-IO for 2 cycles, continue with doublet immunotherapies, or the 99 or the 2-7 combination. We were also were sharing the data of long-term outcome of pembrolizumab in the first line, or prolonged outcome of the chemo-IO first line as well. The DURVA as a consolidation phase was also updated, and the PD-L1 in extensive small cell lung cancer was presented in a longer follow-up. What are the open issues still in the immunotherapy in lung cancer? So if we focus on the different segments, so if we focus on patients with PD-L1 above 50%, so the debate would be, should we use mono or combo in the first line? If we are using combo, what is the combo? Is it pembro, is it atezo or nivo? Or are we combining it with chemotherapy? What chemotherapy and for how long? It is unclear how long should we treat patients who have achieved complete response, and what should we do at the 2 years time point when we do have patients that are still in a very good response and just completed the 2 years time on pembrolizumab. There are still some open questions about some patients with uncommon drivers like BRAF, c-Met, and RET. At the moment, there is no study comparing chemo-IO compared to targeted therapy, and therefore we cannot exclude immunotherapy from those patients. Another unmet need is the second-line therapy for those patients who have progressed on immunotherapy. And of course, we should ask ourselves what is the role of molecular clusters as IO-related prediction, like STK11. Focusing on EGFR-positive disease, and immunotherapy, we may see that if we accumulate the different studies that are mentioned in this slide, we may see and summarize that for patients with EGFR-positive, we nearly see an impact of immunotherapy for those patients, and we should keep it in mind when we approach those patients in lines. That can be explained by the low tumoral mutational burden in those patients with classical drivers like ALK or ROS1 or EGFR that do have a median TMB around 2 to 4 mutations per megabyte compared to other patients with KRAS, BRAF, or others that have a higher TMB. To share with you one of my patients, this is a 74-year-old male who have smoked 20 years, adenocarcinomas. The PD-L1 staining is 60% with a c-Met exon 14 skip mutation with high TMB. This patient was treated primarily by crizotinib for over a year, actually for 2 years, and was in a very good control. Thereafter, on a slow progression upon the PD-L1 above the 60%, he was treated by pembrolizumab for a bit more than a year. Interestingly enough, we may see that the PET scan was worsening very mildly across this period of time, while when we perform the liquid biopsy, in this case, we may see that the amount of the number of clones have been growing gradually over time with a new kind of resistant clones that were effectively treated by crizotinib, as those clones have emerged without being exposed to crizotinib during the time of pembrolizumab. In this time, when he was retreated by crizotinib, the PET scan has shown some improvement with a decreasing of the amount of circulating free DNA. However, he had a brain progression and passed away in December 2018 when he was diagnosed in 2015. So that may actually indicate that those patients do have a prolonged response to pembrolizumab, even though they are having some c-MET skip mutation. What is the update of the CheckMate 9LA? Well, this is a two-arm study comparing the chemotherapy to nivo-ipi plus 2 cycles of chemotherapy. The median overall survival in this study was positive, 15.6 versus 10.9 months, with a hazard ratio of 0.66, with a very nice and plateau for the arm that was treated with the IO chemo. This impact was preserved for both non-squam and squamous cell carcinoma, and it was actually across the PD-L1 group. PFS curves were similar for the first 5 months, and then a split towards a benefit from the nivo-ipi chemo arm. The adverse events in this study, as would be expected, were higher in the 4 drugs arm with the nivo-ipi chemo. However, there was not significant gaps between those. However, there was a price for adding more drugs to this combination. The CheckMate 9LA made its endpoint of overall survival. All the efficacy endpoints have been positive with a hazard ratio of 0.66, and it is another evidence that we do need the chemotherapy when we start treatment with immunotherapy, even if we are using a doublet of nivo-ipi. The CheckMate 2 to 7 was also presented in this study. Just to refresh your mind, this is a pretty much complicated study that has stratified patients upon PD-L1 staining above or below 1%. It was comparing 3 arms in each segment, nivo-ipi, chemo, or nivo alone, and for patients with PD-L1 below 1%, nivo-ipi, chemo, or nivo plus chemo. This study was showing that there was an overall survival benefit for nivo-ipi compared to nivo alone, compared to chemotherapy, even though not in significant numbers, but overall the hazard ratio was 0.79. That was significant for this cohort. So we can summarize this study as a positive for this segment, and specifically the data was really impressive for patients with a PD-L1 below 1%. And as you see here, for those patients, there was a much stronger benefit when we combine nivo-ipi compared to the other arms. PFS was similar, and they were better for the nivo-ipi combination. And adverse events were very well familiar to us today, as we see here, both skin and endocrine and GI toxicity that occurred mainly in the first 6 months. So if we summarize the CheckMate 2 to 7, we can see that the 3 years overall survival rate were 34% compared to 15% for patients with PD-L1 above 1%, which was very impressive. And for those patients with PD-L1 above 1%, the benefit was lower, but again, the 33% in the 3-year survival is a number to remember. The update about Keynote-24, single-agent PD-L1 above 50%, pembrolizumab study, we can see that the 5-year survival was 32%. As previously mentioned, the CheckMate 227 showed a 30% for 3-year survival. Here we have 5-year survival, 31 or 32% survival for pembro alone. A very successful study, and it would be really difficult to compare different cohorts, so it would be difficult to compare those studies, but still a very significant survival benefit. The PFS in this study was also positive, with a 3 years PFS of 23%. Interesting to say that the duration of response for this cohort was 29 months compared to 6.3 in the chemotherapy arm. What was really interesting in this study to see that if we focus on those patients that have completed 2 years of therapy of pembrolizumab, we may see that the 3 years overall survival rate for this cohort is actually 81%. Practically, we may say that those patients that have completed 2 years therapy do have a very high chance to reach the 3-year survival, even without exposure to the drug. Out of this cohort, 12 patients had a chance to be re-exposed to pembrolizumab due to disease progression. And what we see in this interesting cohort, that the response rate was 33% for the re-challenge of pembrolizumab. What is coming next? So there are numerous studies that are combining pembrolizumab plus lenvatinib. We may see many of those clinical trials out there. This is a multiple tyrosine kinase inhibitors that may impact the microenvironment and improve the effectiveness of the immune system. The lenvatinib was presented as this is the running phase of the LEAP 006 189 platform combined with lenvatinib. The running phase showed only safety at the moment and efficacy, very, very preliminary efficacy data, but there is no comparator arm, so it would be hard to tell. The anti-TIGIT is also another promising avenue that we may see in the next, I would say, 2 to 3 years. This is a dual blockade of the immune system, and actually we have at the moment some drugs that would combine anti-PD-1 with anti-TIGIT in the same formulation. So those clinical trials are ongoing, and it would be very interesting to see the results that are coming up. The first human study, also vibostolimab plus pembrolizumab, was presenting with an interesting response rate for those patients. The depth of response is unrelated to PD-L1. However, if you see here, it was patients with a positive PD-L1 staining had a better response rate, response duration, as was shown here on the right side, that is still on. How do we consider what are our considerations for the treatment of those patients? Well, we should combine different considerations who are first comorbidities, CNS disease, tumor burden, etc., histology, what are the drivers, what is the PD-L1, what is the TMB, and of course, what is the drug availability and the which patients to get therapy. One of the interesting data is that some gene clusters may also impact the response to IO. For example, the combination of KRAS and STK11 was found to be a negative predictor for IO as a single agent. In this slide that was published in Cancer Discovery 2 years ago, you may see that a combination of KRAS plus LKB1 showed a very low response rate compared to KRAS plus TP53 or KRAS only. Even though I would like to present you with a case of a very young lady, 49 years old, that have smoked 50 pack years, that had an MSI high with a low disease burden. This lady had KRAS plus STK11. However, on the other hand, had an MSI high in their tissue analysis. So this lady had a right upper lobe disease, KRAS plus STK11. She was treated because of she did have a few lesions on the same lobe. She was treated by carboplatin, pemetrexed, and pembrolizumab for 4 cycles with a significant response even after 1 cycle. Thanks to this response, she was able to go through right upper lobectomy, but the tumor was attached to the esophagus, and she had no nodes or distant metastases. She got post-operative radiation. 3 months later, she has developed pancreatitis and retroperitoneal FDG uptake disease. At that time, she was radiated for the left retroperitoneal nodes and renewed the pembrolizumab. Following this renewal, she has developed colitis, and we had to stop the pembrolizumab. And actually, and this patient at the moment has no evidence of disease. That was actually more than 18 months since she was first exposed to this combination. So even though she was positive to KRAS and STK11, we may see some responsiveness, a significant responsiveness. However, she was also exposed to chemo, and she was also a MSI high. So I brought this case mainly to present a case where KRAS and STK11 should not exclude patients to be in. To summarize my talk, the take-home message would be that immunotherapy is robustly implemented in non-small cell lung cancer. We do have predictors for IO like PD-L1 and TMB, and specifically lack of drivers. Genomic clusters like KRAS and STK11 are negative predictors, but still should be discussed. Liquid biopsy can support the understanding of cluster existence. And of course, there are more questions to resolve, and we have to enjoy our art in oncology. And with that, I would like to conclude and to thank you for your attention. Thank you very much.
Thank you too, Nir. It's a very interesting lecture about in the immunotherapy world. There are just a few minutes, very few minutes for 2 burning questions. The first is in your clinical practice, maybe in the future clinical practice, you may prefer the combination in first-line setting of IO plus IO or chemotherapy plus IO. What's your perspective about that?
So if the question is, so can you just repeat the question? I was not able to hear it very well.
Yes, yes. If you prefer maybe in the future the combination of immunotherapy plus immunotherapy or chemotherapy plus immunotherapy in first-line setting.
So most of the data is supporting the chemo-IO approach. The update of that came in the recent studies actually upon the 227 and the 9LA showed that even if you combine two immunotherapies, it would be important to add chemo on top of it. So the role of chemotherapy on top of immunotherapy is very clear. For patients with PD-L1 negative, there are some possible benefits from the nivo-ipi combination. But in general, I would say that it is clear today that we need the immunotherapy and we do need at least 2 cycles of chemo just to control the disease to be stable. Now, the gaps between the different studies are hard to compare. We do not have a clear comparison of the 9LA to the Keynote 189 or to Keynote 407. So it is upon the personal experience, maybe the availability to the drugs, the expenses of the drugs, which is much higher when you combine two immunos, and of course the safety.
Okay. It's all the good points, Nir. Thank you. And at least you may consider for the future that the number of the patients with the stage 4 disease will survive longer thanks to immunotherapy, in which percentage?
So I'm sorry, but I do not hear the.
Okay. How many patients in the clinical practice you will see as the longer survivor patients? I mean, more than 5% that are the classical answer to the question about the prognosis of non-small cell lung cancer.
So as if we follow the recent studies of showing the 5-year survival or update of Keynote 024, and also if we look on the Checkmate 227 and the other studies, we can see that the 5-year survival is crossing the 30% in many studies, or at least is approaching the 30%. So we are talking about a third of the patients that are going to survive more than 3 years. The other studies even showing that if a patient is reaching the 2-year survival, so the chance to be alive in the 3rd year is even 80%. So the more we expose to IO, the better we see results. And if we're talking on responders, so the prognosis seems to be very good for those patients who are responding to the IO.
Okay.
So I believe that the need for lung cancer experts is going to grow because we see more and more curable disease, and it will not be a rare definition to not like in seminomas, but I hope that we are on the direction of melanoma, at least.
Okay, thank you. Very enthusiastic reply, and I fully agree with you. So is now the time to move for the next speakers. Is Dr. Ignacio Gil Bezo, another friend of mine. Is the director of a medical oncology unit at Universidad de Navarra, Spain. Okay, I remember to mute your microphone. So thank you so much, Ignacio, and you will take some minutes about a neoadjuvant strategy in oncogene-addicted tumors. It's quite a tricky topics. Thank you, Jim.
Mm-hmm. So thank you very much, Diego, for your kind invitation and also our presentation and introduction. So yes, in the next following 10 minutes, I will try to give you some thoughts about neoadjuvant strategies in oncogene-addicted tumors. These are my disclosures, and This is the outline I will try to cover. So first, I think it is important to bear in mind some general considerations about neoadjuvant therapies in general in cancer, not only non-small cell lung cancer. I will try to summarize it in these 6 points. So I think neoadjuvant as well as adjuvant clinical trials should be designed for patients at higher risk of recurrence. And this is important because probably the most benefit is going to be in those patients. At the same time, the type of surgery, I know there are some surgeons in the audience, I think this needs to be very well established up front, as well as to be as homogeneous as possible. I think it is also important to use uniform and rigorous procedures to assess pathologic response, because this is going to be actually at the end of the road one of the major primary endpoints. It is also important to record, as in any other clinical trial, serious adverse events, including surgical and post-surgical complications. And it is completely necessary to conduct a perioperative blood sample as well as surgical specimen collection so we can conduct pre-planned biomarker analysis of response or resistance. And finally, I think it is also important to perform a standardized radiological and metabolic imaging for response assessment. What are the advantages that neoadjuvant therapies can render in this setting? Well, the first is that we may be able to impact on micrometastasis from the very beginning. So we don't wait after surgery and the post-surgical recovery of the patient to start systemic therapy. Another point is also that we may have the ability to test sensitivity of the neoadjuvant treatment that we use. And of course, we may also assess the pathologic response as we considered before. And this is important because we know that for some tumor types, such as breast cancer, for example, it is a relevant surrogate marker of long-term survival. It is also important to mention that for clinical trials, if we are fixing the major or the pathological response as a primary endpoint, this is going to definitely shorten the trial timeline. And of course, we all know that neoadjuvant therapies are generally much better tolerated than adjuvant therapies. Coming back to the non-small cell lung cancer more specifically, and regarding the unselected population, what previous experiences do we have about the benefit of treating those patients in the neoadjuvant setting with chemotherapy? Well, these are 4 phase 3 clinical trials using adjuvant or neoadjuvant plus minus adjuvant therapy using different chemotherapy doublets. And I just want to drive your attention to the around 40 to 50% response rate that we may obtain from these approaches, as well as the 40 to 50% 3-year disease-free survival that we may expect. And this is something to have in mind when we see the results from both immunotherapy plus minus chemotherapy in the neoadjuvant setting, but also the targeted therapy in the same neoadjuvant setting. Coming back to the previous presenter about the neoadjuvant strategy using immunotherapy, I think this is another relevant point to build on when we consider targeted therapy in neoadjuvant setting, because we've seen success in this approach when using immunotherapy alone or immunotherapy plus chemotherapy prior to surgery. This is just the NADIM trial that has been previously mentioned from the Spanish lung cancer group. And I just want to drive your attention to the really outstanding percentage of patients obtaining a complete or at least a major pathological response rate, which is something that we may not expect only for chemotherapy alone. Again, from the same trial, another important point, which is something that we can extrapolate to any other neoadjuvant treatment that we provide to our patients with non-small cell lung cancer, is that we can use those pre-treatment, post-treatment samples to compare and to analyze and identify potential biomarkers of response and resistance. This is just the example of the NADIM trial and how those patients receiving chemo plus immunotherapy actually presented a much more inflamed tumor at the time of surgery. So what about oncogene addicted tumors? Is there a chance to treat these patients neoadjuvantly with targeted therapies? Well, this is something that we can not finally address at this point because the current evidences are coming from these trials. As you can see there in this updated table, we have only, very little experience in very short cohorts of patients studied, and mostly with first generation EGFR TKIs, and we are still pending some other clinical trials which are underway using third generation such as osimertinib, or just even second generation such as afatinib, or for other targets different from EGFR, such as cardiothoracic for ALK positive patients. So I'm going to try to summarize in the next couple of minutes the little evidence that we have so far. So this is a clinical trial using neoadjuvant erlotinib for stage 3A patients. So 13-1 non-small cell cancer patients were tested for EGFR. Those being negative were allocated to chemotherapy first, followed by surgery. Those being positive for EGFR mutations were offered EGFR TKI first, followed by surgery. As you can see here, the response rates were really interesting for the arm of targeted therapies that it would be expected. And actually, we found no progressive disease in that arm. However, in the lower part of this slide, you can see that that did not actually translate into a benefit in terms of either PFS, disease-free survival, or overall survival. This is another interesting trial, although only 19 patients were finally enrolled. So again, we have very limited numbers of patients treated, so we cannot really make final conclusions. And this was restricted to the stage 3A and 2 disease. So those patients, as you can see there, when treated with erlotinib in this phase 2 clinical trial, presented a very nice response rate. Actually, it was around 42% partial responses, 47% stable disease. But again, no final conclusions can be made from such a small clinical trial. This is a different clinical trial using gefitinib as opposed to erlotinib. And the relevant point here is that not only EGFR positive patients were included, as you can see on the right-hand side of this slide, patients with KRAS or even PI3 kinase or other, or even no mutations were included. Of course, those with EGFR mutations with different alterations in the EGFR gene experienced the major benefit from gefitinib in stage 1 to stage 2. But still, some patients also presented a very good response, having no mutations or even PI3 kinase mutations. So this is an interesting, let's say, hypothesis generating interesting trial, but with no final conclusions either. This is a completely different trial, phase 2 clinical trial using, again, gefitinib in a small number of patients, around 30-something patients from stages 2 to 3A. And the most relevant part of this point from this clinical trial is that they actually studied and fixed a cutoff of number of or percentage of viable tumor cells in the pathologic specimen. So they found that for those patients with less than 10% of viable tumor cells after neoadjuvant gefitinib, the disease-free survival was significantly longer, which was not the case for overall survival in terms of statistical significance. However, in the multivariate analysis, they found that not only the number of viable cells, but also the downstaging that the patients presented after neoadjuvant gefitinib, and also the grade of response that those patients received were also significantly correlated with disease-free survival. But probably the most relevant clinical trial in this setting, at least for EGFR so far, that has been performed is the emerging trial. This is a phase 3 clinical trial comparing erlotinib versus GemCis for patients with stage 3A and 2. And those patients were allocated or randomized to targeted therapy or chemotherapy combination, platinum-based doublet. And those patients were finally operated, and then afterwards they actually received also adjuvant therapy. The primary endpoint was overall response rate, and as you can see here, both response rate as well as the disease control rate were much better for the erlotinib arm than the cisplatin gemcitabine arm. Those patients needed to be EGFR positive. I didn't mention that, but that's important. And it is also interesting to see that although there was a clear sensation of benefit in terms of the RO rate, as well as the N2 converting into N0 in the pathological sample for patients receiving erlotinib, this comparison actually did not achieve statistical significance. In terms of survival, we see that those patients allocated to erlotinib presented a much better progression-free survival with a hazard ratio of 0.39. However, this did not translate into overall survival. And this is probably the same problem that we've seen with other targeted therapy clinical trials in the past, in which those patients finally, at some point of recurrence, may receive a standard of care with first, second, or even third generation EGFR TKIs. So that's probably why we don't finally see any overall survival differences. Regarding ALK positive patients, we just have at this point this very limited clinical trial or patient series, I would say, with only 11 patients recorded, in which all but one actually presented partial or even complete response, and only one patient presented stable disease. More importantly, and this is something important for the neoadjuvant setting clinical trials, these patients were also studied with liquid biopsy or with tissue biopsy, and the molecular analysis was performed prior to neoadjuvant and after neoadjuvant therapy. And this was interesting to see how the alterations that were able to be seen may change after treatment. But I think the final answer to whether we are ready to use EGFR or ALK or many other targeted therapies in the future for these patients is needs to have a better clinical trial approach. And this is the Lung Cancer Mutation Consortium, the PROMISE clinical trial that is actually undergoing this research currently. You can see that patients are, prior to any treatment, tested for different alterations, not only EGFR or ALK, but also ROS1, MET, BRAF, RET, etc. And even patients with driver negative are tested for TMB. And according to the results, they are allocated to EGFR TKI or ALK or ROS1, so targeted therapies or immunotherapy alone for those driver negative TMB high, or even chemoimmunotherapy for those driver negative TMB low. And I think this is going to be interesting to see the results. Of course, they are also taking advantage of this design to try to unravel the biology of these tumors and how neoadjuvant treatment actually works in selecting clones, in inflaming the tumor, in many other aspects for biomarker discovery. So my last slide before conclusions is just to mention that liquid biopsy can actually be used in this setting of neoadjuvant therapy in order to characterize and monitor how things at the molecular level go during neoadjuvant treatment. So in conclusion, I think the answer is we are not ready for prime time when it comes to targeted therapies in the neoadjuvant setting. This should be done only in a very controlled clinical trial setting or for very selected cases. However, we are seeing really interesting data coming from the overall response rate, the pathological response rate in some of these studies. However, the small numbers that we are managing so far preclude the obtention of final conclusions. However, there are new studies that are ongoing that may be able to answer on whether overall survival advantage is also the case for this setting. Thank you very much.
Thank you, Ignacio, for this fantastic presentation. It's an overview in the oncogene-addicted world in the early stage non-small cell lung cancer. Just a brief question because we haven't time. Do you agree with this sentence that immunotherapy in the early stages cure the cancer, but the TKI maybe have not this possibility in the same setting?
Mm-hmm. Well, I think when we consider immunotherapy and targeted therapy, we are considering completely different approaches from the biological point of view. So targeted therapies are something that are able to exert a response and a benefit on the patients as long as we provide those treatments to the patient. So when we finish that, the beneficial effect goes away. This is not what happens with immunotherapy. With immunotherapy, we know that not for everyone, but for a substantial proportion of patients, we may have a long-term benefit in terms of probably the memory T cells that are able to recognize the tumor and avoid that tumor to regrow in the future. So I do agree that probably we may never be able to cure patients with targeted therapies, which is not the case probably for immunotherapy, again, for selected patients. However, in this setting, which is neoadjuvant, I think if you really want to provide a much better, response, early response to the treatment, and in order to go for a less invasive surgery, for example, I think this is a valid approach. And what is going to be finally curing the patients is probably surgery. However, we know from the ADARA trial that's just been presented this year that those patients actually, after final resection or complete resection, obtaining treatment with osimertinib may benefit also in the long term. So I think we don't have the final answer to these, but and definitely are completely two different scenarios.
Okay. Thank you also for these insights. And now I don't see any other question or burning question from the audience. So I jump to the second session. It's like a joke. And I would like to introduce my co-chair, the Professor Paolo Bidoli. It's the Director of Medical Oncology Unit that is a co-chair with me this second session. And the second session is about, again, the oncogene addicted, but another phase of oncogene addiction, the rarest disease. So if you want to talk about Paolo, for some introduction, I don't know.
Diego, thank you very much. Good afternoon. Okay, it's a pleasure for me to introduce Dr. Cristian Rolfo. Dr. Cristian Rolfo is Director of the Thoracic Medical Oncology and Early Clinical Trials at the University of Maryland, Marlene and Stuart Greenbone Comprehensive Cancer Center, and is also professor in Division of Hematology Oncology at the University of Maryland School of Medicine. And he will talk about oncogene addicted tumors and what's new about this interesting subject.
Hi, my name is Christian Rolfo. I'm the Director of Thoracic Oncology and Early Clinical Trials at Maryland University in Baltimore, and it's a pleasure to be here today to discuss about the oncogene addicted tumors. I would like to thank, obviously, the organizer and especially Dr. Diego Cortinoves for the kind invitation. He asked me to resume this, summarize this very difficult topic in 10 minutes. I will try to do. I know that I will exceed some of the minutes. This is my disclosures. I will talk to different unusual suspects like MET, RET, NTRK, and ER2. I cannot discuss about the others for the sake of time, but if you have any question, please, you have my email and my Twitter later on to discuss about the other biomarkers and our experience. In excluding the 2020, that was a spectacular year by FDA approvals that we have this year, you see that here the milestone of the history of the novel oncogene in non-small cell lung cancer was a tremendous prolific years that we have the identification of the biomarkers, especially like new biomarkers entering in track, and finally approved for patients, including non-small cell lung cancer. So these kind of biomarkers that now we are applying in also in another concept that is agnostic tumors are coming to select patients and to fragmentate a little bit more the cancer disease in different new disease with different possibilities of treatment. The first biomarker that I would like to talk is about MET. This is a very difficult pathway, we will say, because there are several possibilities as a biomarker. The first one that we was trying to study in lung cancer was the overexpression with drugs, historical drugs like onartuzumab in combination with erlotinib. This was not resulting to be the biomarker for lung cancer. Then we moved to amplification. There are new data coming there, I will show you. And finally, the MET mutation that is seems to be the new star in MET. We have also the opportunity to go for the ligand to inhibit the ligand, and that is something that was performed before with some drugs. Hepatocytic growth factor receptor became a biomarker, but we know that nowadays that some possibilities are coming here also. I will show you in the area of the resistant mechanism or new medications. Different biomarkers in the same pathway, and the MET exon 14 skipping mutation obviously is a star nowadays because we have different results that are very positive in this setting. The first one is the Vision trial, that is the trial that was analyzing the activity of tepotinib in MET exon 14 skipping mutations. There is a cohort also for MET amplification that we don't have still the data. In this trial, I think a good positive mark that this trial have is the opportunity to see what happened in liquid biopsy and in tissue biopsy in terms of response rate. But also one of the negative points for this trial, in my opinion, is that we don't have a disposition or a diversification according to the first, second, or third line. So all the patients were included in the same bag, and that's are the results that we will see. So in this trial presented in ASCO in 2020, the first result, 2019, the first results, we saw that the liquid and the tissue biopsy were very comparable, over a response rate around 50%. With you see here that is the data presented or published in this year in New England Journal of Medicine. There are no differences in patients though, so we cannot see here the difference or the activity in first or second line. But you see here that this in the entire population, some of the patients have a complete response and important waterfall flow activity. If you see that in numbers, 48% in the liquid biopsy, 50% in the tissue biopsy, and the overall duration of response, the duration of response of this trial was around 11.1 months. So this is a very impressive response rate, and this drug is obviously continuing different trials. The geometry trials, MOR1 was the trial that was evaluating in 2 different cohorts in pretreated or treatment naive patients, Capmatinib at the dose of 400 milligrams BID. And the primary endpoint of this trial was overall response rate by independent review committee. In this trial, they were including MET exon 14 skipping, irrespective of the gain copy number of MET by central real-time PCR. And you see here the waterfall plot in the pretreated patients is very consistent, very robust data, and also in very important and impressive data in the non-previous treatment. As well, if we see the swimmer plot, you see here that there are important activity in times of treatment for different patients in previous or non-previous treated. If we put that in numbers, that means 68% of response rate in first line, so in patients naive of treatment, and 41% in patients who received first or second treatments before, so in second or in third line. The median progression-free survival was 12.4 months in the pretreated, in the naive patients, compared with 5.4 months in the pretreated patients. One of the problems that we will face, beside the nice result that we have, that the mechanisms of resistance are there, and in different data that we have seems to be divided in on-target and off-target mechanisms of resistance. So on-target, several mutations were identified and acquired resistant mutations, but also the possibility that we have a different pathway activation, like EGFR amplification, KRAS amplification, or even BRAF amplification is very interesting. It's important to say that unknown is still between 25%. Here in the other publication the year before, they say around 50%. Obviously, we need to test these patients because it's important that we identify this mechanism of resistance in order to treat the patients accordingly. We was discussing about the mutations. I want to discuss also about the amplification. When we have patients that were receiving EGFR mutation TKI treatments, they can develop as a mechanism of resistance and a MET amplification, or MET amplification could be also as a primary driver. We was discussing recently the MET exon 14 skipping mutations. Capmatinib is also acting in MET amplification. You see here the overall response rate in the first cohort of this trial was 29%. Very small number of patients. Obviously, we are talking about 20 patients in this case. Progression-free survival, or median progression-free survival, 4.1. So depends, obviously, in this setting, depends, the different drugs are depending on the amplification ratio, and you see here a copy number, and you see here that the patients who have a high number, copy number, or a high ratio, they have a better possibility to respond to the different drugs, including crizotinib, or in this trial, for example, Capmatinib and gefitinib, or Capmatinib alone. We are waiting for trials like the Savannah trial, that is the combination of osimertinib and savolitinib in patients that were progressing to osimertinib, or the Orchard trial that is also the combination in different settings, like you can see here, specifically in they are including also another biomarker. So in the setting of MET, this combination is also studied. I told you that we are looking for, again, for hepatocytic growth factor receptor and MET interaction. In this case, it's a new drug that is the SIM015. This is a recombinant humanized G1 monoclonal antibody that are going against this MET. This is very selective. In the trial, that is under results. Now we have this presented in ASCO 2020. This trial was a phase 2, including non-small cell lung cancer, c-MET amplify, and MET exon 14 skip in deletion mutations. You can see here the first result, specifically the activity in amplification was around, in the overall response rate, 28.6%. Important activity in the MET exon 14 skipping mutation, but numbers, obviously very small numbers. We are talking about a proof of concept trial. And in the pretreated patients, only one patient was included with a disease control rate there. So we see here some of the patients in blue, you have in solid blue, the amplification with good response. Obviously, majority of the response were done in MET exon 14 skipping mutation, but there are some opportunities for these patients as well with new drugs. And TRAC fusions, this is a very interesting pathway as well. It's important that we remember that in TRAC in normal biology, they are having some important activities like the pain, thermoregulation, the proprioception, the appetite, the body weight. So all these normal functions, when we are blocking NTRK with the inhibitors, obviously can become one of the side effects, like for example, the body weight. In TRAC fusions, we have 3 genes with different partners. It's very promiscuous in number of partners, and we have different drugs coming there. Important that the TRAC fusions are across different tumor types, not only in adults, but also in pediatrics. In non-small cell lung cancer is one of these, but we don't need to forget that this is an agnostic tissue biomarker. It's important that we test these patients because response rates are very high. This is the case of larotrectinib. Overall response rate, 76% of the patients with a complete response. The efficacy is regardless the tumor type, regardless the fusion genes, regardless the age. So it's important that we test these patients. You see duration of response, several patients ongoing. Important in pediatric populations that we are reducing the number of mutilation surgery in this pediatric population. And in another biomarker specifically acting in different tumor types, also in non-small cell lung cancer, you have entrectinib, response rate about 57%, with complete response as well, with a median duration of response 10 months. And finally, important activity also in the brain with intracranial response with measurable disease in patients with brain metastasis. So it's important activity that we need to test these patients. There are other drugs coming, right, like repotrectinib, that is also acting in the brain. It's also, beside the TRAC activity, is a ROS1 inhibitor, less ALK potent, obviously, and now the trial, the TRIDENT trial is trying to see this result in NTRK and ROS population. For LOXO 195, this is a drug that was designed for the resistant mechanism, but obviously there are several things that we need to know about the resistance in NTRK. It's important also that we collect the data of this patient because it's a learning curve process. And we are moving to another biomarker that is the RET. In this case, RET aberrations in non-small cell lung cancer are obviously, majority of them are the fusions, and that is happening around 2% of the patients. The most common in lung cancer is the KA5B, that is the fusion, the most common partner. There are several drugs that we were using before, like cabozantinib, vandetanib, or levantinib, that were not really selective for RET until the arrival of drugs like selpercatinib in the trial Libretto 001, who was a basket trial, were including different cohorts. One of the cohorts in lung cancer included 253 patients. Finally, prior platinum chemotherapy, 184. And you see here in the primary analysis an important activity of the drug, including in patients with prior therapy including patients who receive immunocheckpoints inhibitors or multi-kinase inhibitors. In treatment naive, also important activity with complete response, and the durability of the selpercatinib is also impacted in the progression-free survival with 18.4 months, and the treatment naive patients would not reach the progression-free survival and duration response not reached at the moment of the analysis. This is one of my patients with non-small cell lung cancer, never a smoker, with red fusion. You see this patient was with an impressive disease in the bone. Lung cancer was a pleomorphic carcinoma. He received chemotherapy before, and he was detected with this fusion after once he just started the chemotherapy. He was sent into our study that we have open in our center, but was not eligible for the ECOG-3. And this is the patient we started selpercatinib with an FDA emergency authorization for ECOG-2 or 3, in hemoglobin 8.2, platelet 36,000, and we started with a reduced dose. And you see here, after a couple of months, you have an important activity. The patient was recuperating, is currently ECOG-0, and the hemoglobin and platelets were recuperating very quickly, and also the LDH dropped amazingly. There are new drugs like the Blue 667 or pralsetinib that is also a very potent RET inhibitor. In the ARROW study that was including non-small cell lung cancer patients, important activity, overall response rate 58%, 60% in prior platinum. Seems that the is very active also in regardless to the activity of the checkpoint inhibitor previously treated, and across the different partners of fusions. And obviously activity as well in brain. Seems that the toxicity profile seems to be a little bit different from pralsetinib than selpercatinib. We have already approved selpercatinib and pralsetinib, and there are several studies running for go in first line. Also, mechanism of resistance here in the few studies that we have, since that the MET amplification and the KRAS amplification could be one mechanism of resistance. There is no clear, obviously, in all the patients a mechanism of the resistance, but it's important that we remember that some of the mutations that are acquired resistant mutations are present, and we need to see what we need to do with these patients, obviously, because we don't have at the moment any treatment for them. There are some also, the case of this is one of the cases with the MET amplification. So in this case, we can try, obviously, some of the drugs for MET. Finally, the last biomarker that I would like to talk is the HER2. And in HER2 mutations, we have that is occurring around 3% of the non-small cell lung cancer. We have different drugs like trastuzumab, pertuzumab, monoclonal antibodies, but generally that's activity that we have even from afatinib, dacomitinib, or neritinib as a tyrosine kinase inhibitors was not so effective like the new drugs like the trastuzumab, deruxtecan. And you see here the activity of the former drugs until the arrival of trastuzumab, deruxtecan was not really impressive. We have this trial that was the first one of trastuzumab, deruxtecan in the cohort of non-small cell lung cancer patients. The median progression-free survival was 11.3 months. And finally, the Zenit study that was presented in ESMO 2020 by Sosinski. You have here in the cohort 2 of non-small cell lung cancer, specifically with exon 20 insertions, these kind of mutations, the overall response rate was around 27.8% and 35.1% in the evaluable patients. The disease control rate, 63% and 61% in the evaluable patients, and the primary endpoint was MIT. The duration of response was 5.1 months, and you see here 70% of the patients have a reduction of the tumor reduction and shrinking in this waterfall plot, including some important partial response of the patients. There is another drug that is tarosotinib, and this is a pan-HER2 inhibitor specifically in the RAIN study, in the trial design of the RAIN study that were including exon 20, EGFR and HER2, the activity of these drugs was seen in the, specifically in these exon 20 mutations with some patients including an important reduction, almost a major partial response, 48% of reduction confirmed, 44% in some of the patients, and stabilization of the disease. Also, specifically in the HER2 cohort, several of the patients have an important time of treatment, and several of them obviously progressed at a certain point. So it's, as a take-home message of all these amazing numbers of patients included in the trials with a good response and the biomarkers, so it's important that we test our patients. But it's important that we test our patients, that we are not running to get treatment with the standard of care, because you see the results that we have here are completely different. So we need to test our patient at least to determine who will not have a benefit of immunotherapy, because some of the doctors are running quickly to have the treatment, and we are not waiting for have the result of the molecular tumor board. So it's important that we test our patients. Here you have my Twitter and my email, and I would like to thank, and I'm open to take questions after the presentation. Thank you.
Okay, Christian, thank you so much for this brilliant presentation. And the last statement is the best to manage our patients. So please test all the patients. But we are ready now to have the possibility to use a comprehensive genomic profile for all the people that start with patient journey. I mean, all the hospital has this possibility today. Christian.
Yeah, obviously, it's important that we test our patients. So it's still incredible that several of our patients are coming to consultations with second opinions that they were treated in other centers or in private practice here in the United States, for example, that they don't have any molecular profile done, and they were already receiving 2 or 3 lines. So it's important that we test, because nowadays we have all these drugs, and I remember some months ago I wrote an editorial in Lancet about NTRK, and I say this is a diamond ready to sparkle. It's like having a Ferrari without driver license. So we need to obviously test the patients and try to get the drug. Another problem that we have obviously is that not all the countries around the world have access to the drugs. And that is something that is important, that we are working on that with advocacy patients as well, in order to change that, have access to the drug, and obviously lose our ego and send the patients to the referral centers when they have open trials for these specific biomarkers.
Okay. So thank you, Christian, but the time unfortunately is past now, and I see also many flags behind your shoulders. So it's the sign that you are an oncology around the world.
United States.
Fantastic. So now we can switch my presentation with Tommy D'Amico. If Dr. Raveglia would like to introduce the colleague.
Yeah. So let's go on. The next speaker is Dr. Tommy D'Amico, professor of surgery from Duke University, US. Yesterday he told us about the Nelson study, and today his presentation is entitled Concomitant Neoadjuvant Radiotherapy versus Neoadjuvant Chemo versus Surgery Upfront. Please, Professor D'Amico.
Thank you. Are you able to see that?
Yeah.
So I have no disclosures. The NCCN guidelines for stage 3A and 2 disease that we would consider operable includes induction chemoradiation therapy, followed by surgery without progression. In this algorithm, there is no role for intentional adjuvant therapy only in patients with known disease at the N2 stations. In fact, in an earlier algorithm for stage 2 patients, after surgical evaluation, patients likely to receive adjuvant therapy may be treated with induction therapy as an alternative for patients that have tumors greater than 4 centimeters or N1 disease. This clearly shows the power of induction therapy based on NCCN experience. Within the ESMO guidelines, however, there is a guideline that states in case of single N2 station disease, resection followed by adjuvant therapy would be an option. However, this is a grade 4 recommendation with has grade 4 evidence with grade C level of recommendation. There's very little evidence that this is a guideline, and yet it seems to be practiced worldwide. So I have 6 questions. Is induction therapy effective for N2 cancer? In the 2 most important prospective randomized trials, it demonstrated that it was. In a recent meta-analysis, or in a 2006 meta-analysis of 7 studies, induction therapy plus surgery was better than surgery alone. In a more recent meta-analysis of 13 studies, again, there was superior overall survival with induction chemotherapy compared to surgery alone. The question of chemotherapy versus chemoradiation therapy is also often asked. The most important study that addresses this is the SAC trial looking at chemotherapy versus chemoradiation therapy plus surgery, and there's no difference in adding radiation therapy. We performed a meta-analysis of all available studies at that time and presented this at the World Congress of Lung Cancer. Induction chemo alone is associated with equivalent survival and fewer complications, and we tested this in our own group of patients, 111 patients who underwent lobectomy for N2 disease after either chemoradiation plus surgery or chemotherapy plus surgery. Interestingly, over the period of time after 2007, our use of induction chemotherapy alone went up as the evidence became clearer and clearer that adding radiation therapy added no value. As well, during the period of time, our use of minimally invasive techniques also increased. There was superior survival with induction chemotherapy alone compared to chemoradiation therapy, although I suspect this represents selection bias rather than a true superiority of omitting radiation. Interestingly, also, those who underwent pathologic restaging had a significantly superior 5-year survival. So this is the overall survival for induction chemo versus induction chemo plus radiation, demonstrating a clear lack of disadvantage and the advantage of adding mediastinal restaging. So is induction chemotherapy effective? There is strong evidence that it is effective, and evidence supports the use of induction chemo alone without radiation therapy. Question number 2, is compliance with chemotherapy relevant? In this famous breast cancer study, the Milan study, first authored by Dr. Bonadonna, the difference between having at least 85% of the planned regimen versus anything less than 85% of the regimen was clear. And all of those who had less than 85% had similar survival as control. And we must remember that there is a dose response rate to chemotherapy. Chemotherapy is not a vaccine. Is there a compliance difference between chemotherapy in the induction and adjuvant settings? These are 2 meta-analyses that looked at adjuvant therapy, so across multiple patients, multiple studies, and approximately 65% of patients who receive adjuvant therapy can be expected to receive 2 to 3 cycles. The ideal reception of 4 cycles wasn't even addressed, with a modest 4% improved survival. In the induction setting, chemotherapy is given at a much higher, more than 80% compliance rate with an even greater increase in survival. And in the one study that compared them both, there's a clear improvement in adoption of chemotherapy in the induction setting. And then most recently, a meta-analysis published last year of 18 eligible trials comparing various ways of treating N2 disease, induction chemotherapy followed by surgery, followed by adjuvant therapy, which is the NCCN guideline, was superior to all other treatments, including surgery alone with a large hazard ratio, surgery plus adjuvant radiation, and most relevantly, surgery plus adjuvant chemotherapy. So is there a difference in compliance? There is a 15 to 20% difference in chemotherapy compliance, and evidence suggests an improvement in survival with induction versus adjuvant therapy as well. So what do we learn by giving adjuvant chemotherapy? We don't learn anything. What do we learn from induction chemotherapy? As has been said in previous speakers, we are able to address the biology of the tumor and assess the sensitivity and resistance of various agents for phase 2 trials by measuring the radiographic response, the pathologic tumor response, the pathologic nodal response, as well as serum immune response for immunotherapy, in addition to the treatment of earlier metastasis. And this is just one way to measure a response by nodal status, and 3 prominent studies have demonstrated the profound difference in survival by downstaging. So finally, what is the future of surgical treatment of stage 3A N2 disease? The Pacific study really put this on the map for potentially surgical patients, although this was a non-surgical study comparing the use of durvalumab versus control consolidation therapy after definitive chemotherapy and radiation therapy. And durvalumab, as we all know, demonstrated a profound improvement in survival at 1 year, and then at the most recent publication this year in JTO at 3 years. So how does this relate to surgical patients? Well, if you see in the algorithm that for inoperable stage 3A disease, only one treatment is considered acceptable, it's not long before radiation and medical oncologists will potentially use that for all patients. Many phase 2 studies have been published, including our publication in Clinical Cancer Research on ipilimumab and the Memorial Sloan Kettering Johns Hopkins publication on nivolumab. Most recently, we presented our results with induction pembrolizumab at the AATS. We looked at patients with stage 1B through 3A, although the majority were N2 disease, received 2 cycles of induction pembro only, followed by resection, and then followed by chemotherapy with or without radiation as standard, followed by 4 more cycles of adjuvant pembro. 25 of those patients have undergone resection, and only 1 had a delay prior to surgery due to thyroiditis. All underwent R0 resections with MLND. 72% were completed by a VATS approach. 20% of the patients required conversion, and 8 had an intentional thoracotomy. Most of the patients underwent lobectomy, although there were other procedures. Notably, the significant pathologic response, meaning more than 50%, was noted in 80% of patients. This is with 2 cycles of pembrolizumab only. And major pathologic response, as defined as greater than 80%, was noted in nearly 30% of patients. Many studies now are testing the use of induction therapy in the induction immunotherapy in the setting of surgery. This is the trial that we are accruing to called Aegean, looking at platinum-based chemotherapy with durvalumab, followed by surgery, followed by either durvalumab or placebo. And we'll see how this accrues. I think it's critical that we accrue to this or similar studies to demonstrate that surgery after induction therapy with immunotherapy is safe and effective, or stage 3A patients will all become non-surgical. So in summary, the standard of care for stage 3A N2 disease is induction therapy, and it is underutilized if you look at publications across the globe. Induction therapy has superior compliance and survival versus adjuvant therapy in these patients. It treats micrometastasis earlier. It allows you to test the biology of the tumor. It allows you to assess pathologic response, which is important prognostically, as well as in trial design. it provides a role for induction immunotherapy, even though durvalumab was used in the post-treatment setting for stage 3A unresectable. For patients that we think are curable, there's no role for adjuvant immunotherapy after complete resection. And finally, it is essential if surgery is to be used in the future. Thank you again for the privilege of being on the faculty for this wonderful seminar.
Thank you. Thank you to Dr. D'Amico for this presentation. If you want to add something, Federico.
Oh, I just want to thank you, Professor D'Amico, for yesterday and for today, and nothing to add. If you have any question, otherwise,
I appreciate being invited. I was glad to participate as long as I could. Regretfully, I must leave now.
Yeah.
And I appreciate allowing my talk to go now.
Thank you very much.
Okay,
Take care.
thank you. Thank you.
Ciao.
Bye-bye.
Bye.
So now we can change and can move other speakers, because also Federico Capuzzo that I introduced have some issue to stay longer with us. So I ask the presentation of Federico Capuzzo. Federico Capuzzo is a director of Medical Oncology Unit at Istituto Tumori Regina Elena, Rome. And your talk is about the treatment of unresectable stage 3 lung cancer. Please, Federico.
Thank you, Diego. And really, I want to thank you for the kind invitation. Now I try to share my screen. Okay. So when we talk about treatment of stage 3 non-small cell lung cancer, we probably discuss about the therapy of one of the most difficult to treat disease. And here I just summarized the treatment, the options that generally we offer in our practice for patients with locally advanced disease, in which we have a group of patients with non-resectable disease, in which the standard therapy is concomitant chemoradiation followed by immunotherapy. And then we have another group of patients in which generally we consider surgery as an immediate treatment or after an induction therapy in what we call the marginally resectable disease. So this is the outline. This is what I'll present you today. I'll focus in the options that we have in surgically resectable disease, the option with neoadjuvant immunotherapy. And then I'll very quickly, because many of these data has been already presented, I'll discuss you some data on unresectable local advanced disease, starting from the standard option and moving quickly to the limitations that we have at the new potential perspective. In operable disease, we have a growing interest of immunotherapy with many data that has been produced during the last couple of years. This is the first publication that was presented in the New England Journal of Medicine 2 years ago, showing for the first time that neoadjuvant nivolumab, so immunotherapy, can be effective in inducing pathological response in patients with operable disease. And importantly, that was observed irrespective of the clinical characteristics of patients, particularly the exposure of the history of smoking exposure, and also irrespective of PD-L1 expression. We know that PD-L1 is really a weak predictor for efficacy of immunotherapy, and this finding was also confirmed in this study in the neoadjuvant setting. Starting from this trial, additional trials were presented last year during the ASCO meeting. In one trial, atezolizumab, a single agent, was tested in a preoperative setting, and in another trial, two different immunotherapy options were considered, nivolumab single agent or the combination of nivolumab together with ipilimumab. And both trials, both studies confirmed that a major pathological response was observed in approximately 20% of patients, and probably the benefit was higher, arriving up to 30%, by using the combination of nivolumab together with ipilimumab. During the ESMO meeting this year, also were presented additional data with confirming the efficacy of immunotherapy, even as a single agent. This is a very interesting trial that was presented by the French group. This trial was led by investigator from Gustave Roussy in Villejuif, Paris, showing that even a single dose of atezolizumab was able to induce a reduction of the tumor, also with major pathological response that was observed in approximately 15% of patients. So this is clearly an indication that immunotherapy has a potential relevant role in the neoadjuvant setting. Also with additional data, with additional drugs, during the ESMO meeting were also presented data with another agent, durvalumab, that we know very well, particularly in locally advanced unresectable disease. In this trial, the UNESCO trial, again, durvalumab confirmed that it is an effective treatment and also was a very tolerated agent. You can see here that grade 3 and 4 toxicity that can in some way preclude the possibility of moving to surgery was not present in this study, with very mild toxicity consisting in grade 1 or 2 adverse events. These are the data we have using monoimmunotherapy, or in any case using immunotherapy alone. But there is a growing interest in using in the neoadjuvant setting the association of immunotherapy together with chemotherapy. And the first trial was the NADIM trial, in which nivolumab was used together with a combination of paclitaxel and carboplatin. This trial was very interesting because it showed an impressive major pathological response occurring in up to 80% of cases. So clearly this approach is extremely effective. It seems at least extremely effective in the neoadjuvant setting, and the combination of chemotherapy and immunotherapy seems more effective than immunotherapy alone. And in fact, many other clinical trials are currently ongoing or were recently completed, including the CheckMate 816, for which we already have a press release announcing that this trial is a positive trial because we know that this study met the primary endpoint of pathological complete response. So it is possible that in the next future, the neoadjuvant chemoimmunotherapy could become one of the standard options in management of operable stage, early stage non-small cell lung cancer. Moving from the resectable disease to the unresectable disease, we know that concurrent chemoradiation is the standard treatment. Unfortunately, in our country, in Italy, many centers are not using concomitant treatment and they are still using sequential approach, but we know clearly that concomitant chemoradiotherapy is superior to the sequential approach. And also we know that after concomitant chemoradiation, there is no reason for giving maintenance chemotherapy. This is an old trial that was published in 2008, clearly showing that maintenance docetaxel was completely ineffective. Today, the standard approach is represented by immunotherapy based on the data that already were presented by the previous speaker from the Pacific trial. So very quickly, I just want to remember you that now we know that the durvalumab maintenance after chemoradiation increase overall survival. We have almost 50% of patients alive after 48 months. So this is a very impressive result. And this benefit is present in all subgroups except the group of patients with EGFR mutations and also the group of patients that were completely negative for PD-L1. And probably this finding could be influenced by some imbalance in the two groups, because that was a non-planified analysis. But anyway, based on this data, we know that at the present time in Europe, we cannot use durvalumab maintenance in patients that are completely negative. The problem coming from this trial is also the how can we integrate immunotherapy together with radiation therapy? And during the ASCO meeting, were presented additional data with pembrolizumab, in which the chemoimmunotherapy was used concomitantly with the radiation therapy. And we know from this trial that this approach is potentially feasible with no increase in an exceeding risk of adverse events. What are the limits of the, and what are the new perspective that we have in our patients? What are the limits? We have important limits from the Pacific approach. And the most important limit is represented by the options that we can offer to the patient if, of course, the patient relapses. So we have clearly two groups of patients. We have some patients relapsing during the therapy, and we have patients relapsing at the end of the durvalumab therapy. At the present time, we don't have any standard approach for these patients. And this is the reason why we designed a clinical trial, and we will start with this trial very soon, in which we are exploring different strategies of treatment according to the timing of durvalumab failure. In general, outside of the clinical trial, in clinical practice, the recommendation could be of using a standard second-line therapy if the patient fails during durvalumab, and to offer standard chemoimmunotherapy for patients failing after the end of maintenance durvalumab. Of course, it's important also to define new potential combinations, and many trials. This is a slide that is that I maintained very crowded, just to show you that we have many different combinations that are currently under investigation. And of course, we hope that with new combinations, including new drugs and new strategies, we can really increase the possibility of surviving of our patients. So in conclusions, stage 3 certainly is a very heterogeneous and very difficult to treat disease, in which we need certainly a multidisciplinary approach. In surgically resectable stage 3 disease, neoadjuvant immunotherapy could increase the cure rate. At the present time, this is not recommended in clinical practice, but probably will enter in our daily clinical practice if the trials will confirm the benefit that we already observed in preliminary studies. And it seems that the combination with chemotherapy, so chemoimmunotherapy, is at the present time probably in this setting the most promising treatment. In unresectable disease, standard therapy remain a concomitant chemoradiation followed by durvalumab, with new therapies and new interventions that we need in case of failure of this approach. So this is my last slides. I don't know if you have any question. Thank you, Diego.
Thank you, Federico. It's a very interesting presentation. We have no time to make some question about your perspective in unresectable non-small cell lung cancer, but just a comment about your last trial that you designed. It's very, very interesting. And in my opinion, we try to understand how our patient may be treated after chemo, radiation, and durvalumab. So it's very, very good point in this design and this trial. So reasons for that. Okay.
Thank you.
Diego, I think it's time for me, because now I have to introduce you. Dr. Kotinovic is Vice Director of Medical Oncology Unit and Director of a Lung Unit at San Gerardo Hospital in Monza, and Assistant of Oncology of School of Medicine and Surgery, University of Milano Bicocca. And Diego has cut for himself a very difficult subject, I think, about small cell lung cancer, one of the most neglected disease of the chest organ. Please, Diego.
Colleagues, it's a great pleasure to me to be a part of the 7th International Thoracic Oncology Symposium in cooperation with Lung Cancer European Meeting. In this online edition, due to the COVID emergency, my talk is about small cell lung cancer, between a new dawn or the same old refrain, in order to point out the challenges and the novelties in this kind of disease. Here are my disclosures. I would like to divide my speech in two main topics. In the first part, I would like to share with you some new information about the histopathological features of small cell lung cancer, and then the change in the paradigm of first-line setting after 40 years of successful treatment, and then some indication about some new ways to do radiotherapy in this disease. In the second part, I would like to point out your attention about the challenges in this disease, in particular in refractory and relapsing chemotherapeutic resistance patients. And then we can conclude our discussion. So we can start from the novelties. Till today, small cell lung cancer is considered as a monolith, without any division in histopathological features or oncogene drivers. And this is the key point in order to understand why so many new drugs are quite inconcludent about this disease. The differences respected to non-small cell lung cancer are quite evident. In non-small cell lung cancer, in fact, today we observe more or less 7 or 8 different oncogene driver non-small cell lung cancer in order to apply the right drug to the right histology. In small cell lung cancer, the principle of one treatment fits all is already done, and the results are obviously quite inconcludent. But in the last few years, many research subgroups are observed many differences in small cell lung cancer disease. In particular, thanks to the observation of different transcriptor factors, today we propose a new classification of small cell lung cancer divided in 4 subgroups. This division is not so easy to apply in clinical practice today, but may lead in some differences in the behavior, in the aggressivity, and also in the possibility to do the right drug to such a subgroup. For example, 17% of the population of small cell lung cancer has some features like inflamed tumors. These hot tumors are enriched from an infiltration of T lymphocytes, and probably in this subgroup of patients, immunotherapy in combination or alone may be very active. In fact, today we know very well that immunotherapy is not a good treatment for all the patients. So this is a proof of concept, obviously, and in the next few years, probably we try to understand if immunotherapy is a right drug for this subgroup of population. So in the many few years, when we observe the division of this proposed classification, we observed that every subgroup has some genes or some transcriptor factors that may enhance the probability to have a right drug. For example, in the NeuroD1 subgroup, the AURCA inhibitors are active, or in the first part of these graphics, we observe, for example, the activity of antibody anti-DLL3 that in the whole and general population are not so active. Obviously, in all this kind of subgroup, probably we can find some drugs very, very active. Another part of the change is derived from the first-line treatment. After 40 years, we can change the rules of chemotherapy alone in first-line setting. The Empower 133 was the first phase 3 trial in which anti-PD-L1, atezolizumab, an immune checkpoint inhibitor, was combined with chemotherapy and compared with chemotherapy alone in a group of patients not pretreated and suffer from extended stage small cell lung cancer. In this phase 3 trial, carboplatin plus etoposide plus atezolizumab was compared to chemotherapy alone plus placebo, and in patients that arrive at a maximum of the benefit of the combination, receive atezolizumab or placebo as maintenance treatment. This study has a two co-primary endpoints, median overall survival and median progression-free survival by investigator assessment. And the final results of the updated overall survival, one co-primary endpoint, revealed that the combination of chemotherapy plus atezolizumab was superior in terms of median overall survival, and the overall population reached the median overall survival of 12.3 months instead of 10.3 months of the placebo plus chemotherapy. But it's very, very important also to point out your attention in the right side of the Kaplan-Meier curves, in which the 18 months overall survival population was 34% respected to 21% of the population that received chemotherapy alone. The meaning is that the magnitude of the benefit of the combination of chemotherapy plus atezolizumab is in particular to give the opportunity to have some longer survival population. Thanks to this kind of phase 3 trial, the combination of chemotherapy plus atezolizumab changed completely the first-line setting opportunities. But we have also other trial in the first-line setting. The Caspian trial is a randomized phase 3 trial in which the same combination of chemotherapy was given with a combination of durvalumab, another anti-PD-L1 antibodies, or the third arm of the combination of chemotherapy plus durvalumab plus anti-CTL4 antibody tremelimumab. Again, in this subpopulation, the patients that receive the maximum of the benefit continuing with maintenance of durvalumab, or in the arm with chemotherapy alone, also the optional cranial prophylactic irradiation. The primary endpoint of this study is overall survival. Again, also in this study, we observe a benefit of the population that received durvalumab in combination with the carboplatin plus etoposide combination. We observe also that the addiction of tremelimumab do not improve the median overall survival. And again, also in this trial, we observed that the combination of chemotherapy plus immunocheckpoint inhibitors was superior respect to chemotherapy alone. Also, the combination of chemotherapy plus durvalumab is granted by FDA, EMA, and also more recently in the AIFA, in order to have a second opportunity for this population. The third study is the Keynote 604, in which the same combination was given with the addition of pembrolizumab, an immunocheckpoint inhibitors and antibody anti-PD-1. The trial design is similar to the Empower and Caspian trial. Again, the patients received the triplet combination instead of the double combination plus placebo, and then the maintenance with pembrolizumab or placebo. The primary endpoint was the progression-free survival, and from a statistical plan, if the progression-free survival was verified, overall survival was subsequently tested. Unfortunately, in this trial, there is a trend in the improvement of median overall survival, but is not statistically significant due to the statistical plan. Many comments are to do about these results. Probably there are an enrichment of poor performance status and maybe a higher number of patients that suffer from brain metastases that enrich the arm, the experimental arm of the combination of chemotherapy plus pembrolizumab. In order to summarize all these data, we can observe in the subsequent meta-analysis, the last meta-analysis was published in 2020. We observed that the combination of chemotherapy plus immunotherapy improve all the efficacy endpoints, in particular median overall survival, progression-free survival, and objective response rate, giving the opportunity to our patients to receive the combination of chemo plus atezolizumab or durvalumab that are now the present in the first-line setting. Another good news came from the use of prophylactic cranial radiotherapy in all patients that receive chemotherapy. In historical trial, we observed that PCI is effective in order to prevent the growth in brain metastases in small cell lung cancer, and the gold standard is to give prophylactic cranial irradiation in all the patients that receive chemotherapy and may derive a benefit in order to complete or partial response. Many meta-analyses and many clinical trials reveal that PCI reduce the incidence of symptomatic brain metastasis and prolong overall survival. More recently, a randomized clinical trial in which the patients that derived the same benefit to chemotherapy were followed up by MRI instead of CT scan. And there are a group that receive PCI or not receive PCI. Again, the patients that receive PCI observed a reduction in the probability to develop brain metastases. But if we follow up this patient by MRI instead of CT scan, we observe that overall survival is quite superimposable. The meaning is that MRI can avoid the use of PCI in this subpopulation. So if we balance the risk and benefit of the adverse event due to whole brain radiotherapy in this population, probably in the future, PCI was avoided thanks to the optimal follow-up sequence with MRI. But unfortunately, not all the advances in first-line setting and in the PCI were observed also in the setting of refractory patients to the first-line treatment. In this population, we try to divide historically the patients amongst patients with refractory first-line setting or sensitive platinum chemotherapy. In this group of patients, the patients that remains in a good performance status may receive a rechallenge of chemotherapy that contain the platinum doublet plus etoposide in sensitive platinum subpopulation, or topotecan that remains up to today one of the drug registered for the second line indication. More recently, a phase 3 trial tried to compare two rechallenge strategy in this population of platinum sensitive patients, and observed that the rechallenge of the combination of platinum plus etoposide respect to topotecan is not superior in terms of gain of median overall survival, but median progression-free survival was superior to the combination of the doublet. Again, when we observe a balance between the risk and benefit of the combination instead of the monochemotherapy, probably this kind of trial depict and show that the combination is too heavy in our population re-challenge after first-line setting. A new hope probably arises from the ground from this single-agent phase 2 basket trial with lurbinectedin. Lurbinectedin is a new chemotherapeutics compound that has also some immunomodulatory activity. This phase 2 trial enrolled patients already exposed to chemotherapy and in some subpopulation of immunotherapy pretreated patients that receive lurbinectedin as monotreatment. The population are also stratified by sensitive or resistant to platinum doublets treatment. In this subpopulation, we observe an activity, in particular in sensitive to platinum-based treatment. The median overall survival was more or less 12 months. These great results conducted by this phase 2 trial give the opportunity to FDA to accelerate approval of lurbinectedin in this refractory setting. However, overall, as you can see in this slide, median overall survival was 9.3 months, not too longer different than the historical control. So, to conclude regarding small cell lung cancer, the future maybe will be bright thanks to the dissection of small cell lung cancer in different subgroups, in order to understand not only the histopathological factors, but also the oncogene and transcriptor factor that can perceive, in particular, to the new drugs that can apply in the phase 1, phase 2, and then phase 3 trial. However, till this day, probably it's very important to remind that this kind of small cell lung cancer is linked to the smoking exposure. So the new deal is obviously to prevent this disease, and to stop smoking is the right rule. And I would like to thank you for your kind attention.
Okay. Thank you very much, Diego, for this fine review. Finally, it seems that something has changed in this tumor. Please, now I think I don't think if there is a question.
No, maybe we have no time to further questions. So, Federico, if you want to introduce.
Yes. Next speaker is a surgeon, thoracic surgeon, and it's my pleasure to introduce a very famous thoracic surgeon, the past president of the European Society of Thoracic Surgery, Dr. Kostas Papagiannopoulos. He will address the key point, which is the role of adjuvant therapy for early-stage lung cancer. Please, Dr. Papagiannopoulos.
Good evening, Federico. I hope you can hear me.
Yeah.
Fantastic. I would like to thank the organizing committee for giving me the opportunity and the honor to be part of this wonderful 2 days. I had the opportunity to see all the presentations, and they were all great. It's a pity we were not able, all of us, to be together, actually, but hopefully by next year things will be a little bit better. So I'll share my screen with you now, and are you able to see it? Are you able to see my screen? Can you hear me?
We hear you, and we see the screen.
Fantastic. I mean, unfortunately, I was wedged eventually in the program at the end, where we had giants in oncology that they have already spoken quite a lot about my presentation. So I will give a more pragmatic and philosophical approach to that. I have no disclosures related to this. So we know that adjuvant treatments seem to continue to have a role in stage 2 and 3 disease. This is a study performed in 2008 from the lung adjuvant cisplatin evaluation group with 4,500 patients. And obviously, that study showed that adjuvant treatments and surgery in the management of lung cancer, they can give an absolute benefit of survival, approximately 5% in the study of 5 years, and a disease-free survival of 5.8%. But that at the cost of increased toxicity and cardiovascular complications with a chemotherapy of 1.4%. Specifically, there were concerns of toxicity and complications on patients that they had a reduced performance status of 2. But what arose from those initial studies and the concerns was that at least 1/4 of these patients were not able to complete the chemotherapy, either because they refused it or because of the toxicity. So this is the rationale and the potential advantages of neoadjuvant treatments. And I know that Dr. Matteo and Professor Pellet, they have already spoken about most of them. I have actually highlighted the ones that they are very relevant and practical to us as thoracic surgeons. Obviously, therapy may be better tolerated before surgery. In some institutions, the induction treatment is utilized as a window period to see whether any unsuspected metastases will develop, and obviously evaluate comorbidities before the local therapy is initiated. Obviously, it gives us the opportunity to assess the sensitivity and resistance to agents being used in induction. We can look at the residual tumor and the surrounding microenvironment, where we can evaluate the reasons for lack of benefit and different responses. And then further down, I think reduction of tumor size or reduction of tumor burden might facilitate our surgery as thoracic surgeons, but also increase the chances of operability when we induce a pathologic response. So there's been some early work on neoadjuvant treatment. This is a study back in 2010 where 624 patients were randomized, and they have received pre-op chemo and surgery versus surgery and post-op chemotherapy, with a primary endpoint of disease-free survival. And unfortunately, that study showed that there was no real difference. So the conclusion was there was no significant difference in the overall disease-free survival. There were some concerns that this was an underpowered study. It was a mixed bag of patients from different stages. And at that time, because it was a multi-institutional study, there was no standardized radiological or pathological staging before surgery took place. But there were some messages that came through those early studies. And obviously, one of the messages was that neoadjuvant treatment seems to be better tolerated from patients compared to the adjuvant regimes, that it does not increase really the surgical morbidity and mortality. And there was an encouraging number of complete response of over 50%, which means that you might have a stage migration and facilitate surgery as well. What was also important was that the 5-year survival obviously was favored in those that they had a radiological response or a complete pathologic response, although I think that to that day, we are not entirely sure of how we're going to be able to select and isolate this group of patients before they have their surgery. Another study in 2014, where it was a meta-analysis with 15 randomized trials, almost 2,500 patients, primary outcome, overall survival. And in this study, there was a 5-year absolute survival benefit of 5%, equal in stage 1 and 2, but also a 13% reduction of risk of death on people that they had neoadjuvant treatment. Messages from that meta-analysis: unfortunately, 12 of those trials did not complete accrual, but the neoadjuvant treatments were very well tolerated, and it seemed not to influence the surgical mortality. And obviously, we come from the last 2 to 3 years, and I have seen the explosive enthusiasm from all the oncology colleagues today into this meeting about the use of targeted treatments, about the use of immunotherapy. This is one of the completed studies from Ford, and although it was only 21 patients with 2 cycles of neoadjuvant nivo, they looked at safety and feasibility, tumor response, expression obviously of PDL and mutational burden. And the study actually allowed almost all patients to go through surgery. There were no real delays, with a very good major pathological response, but also the importance of the expansion of the neoantigen-specific T cells. And although there was a recurrence at 18 months of 73%, the overall survival rate was 95%, and the relapse-free survival of 69%. And it showed that immunotherapy is essentially, or it looks essentially that it is safe. One of the practical messages is that the radiological response does not correlate with the pathologic response. We see that with immunotherapy, a pseudo progression of the disease, and we have to be very careful in utilizing simple radiological studies like CT scans to evaluate the response on immunotherapy. And obviously, we were able to establish the hypothesis that the neoadjuvant treatment will most probably deal with micrometastases that they go undetected before surgery by increasing, obviously, circulating T cell clones. These are the completed studies. I have to admit that we have seen major pathological response in some of them in an impressive way, up to 80%. We have seen also a complete pathologic response that ranges from 5% to 71%. But we must not forget that some of those studies contain a mixed bag of treatments, which is not just immunotherapy, but also immunotherapy with chemotherapy. And we have heard earlier on of how important chemotherapy most probably remains. These are the studies that are underway, some of them small in number, some of them bigger ones, but I think we will get more results when it comes to neoadjuvant management on early stage lung cancer. So in conclusion, there is no doubt that neoadjuvant chemo and or immune therapy, they look very promising in early stage lung cancer. I think we can safely progress to surgery and we have no real recorded delays, but there are some practical aspects that we need to keep in mind. For us, it's important in surgery that the reduction of tumor or the reduction of tumor burden might be important to provide clear margins, especially when we have marginally resectable or marginally operable patients. I think the pathologic response is important that we can attack micrometastases, not by killing cells, but most probably inducing a wonderful, sometimes immune response by the host. We need on this pathway most probably to have tissue pre and post surgery because it will guide adjuvant protocols in the future. And obviously when we want to give targeted oncogene treatments. There are several questions, I guess, we still need to answer ourselves, and some of them I've seen them on the chat. How do we integrate immunotherapy? Do we give a single agent? Do we give multiple agents? Do we give a combination with chemotherapy? I don't think that we have definitive answers on the optimal duration of immunotherapy as an induction treatment. And it is a question whether we can essentially persuade all policyholders around the world that money needs to be released. So immunotherapy or induction therapy overall should be part of all lung cancer patients' pathway. And I guess we can use that. We're going to use the pathological response as a surrogate endpoint for survival. Now, I'm still not entirely sure how can we identify those patients that will benefit. We rely quite a lot on tissue sample, but I think we will be moving on to easier ways and less complex ways of identifying tumor markers in patients. And I will finish by saying that we do have future aspirations, and I share it with the rest of the people. But the perfect ingredients for me would be to treat from all the patients only those that we need. Although Tom D'Amico mentioned that every single patient needs to have induction treatment, I still have some questions and reservations about that. We have to prevent by over-treating people and providing a financial bleed to all healthcare systems. I think we need to treat patients with induction treatments with a pathway which will eventually be less complex than what it is, the current one. And obviously, we have to be 100% sure that we can treat people without added punishment on their morbidity and mortality. I have heard today and also seen in several studies how people become obsessed about offering extra days or weeks or months in the survival of those patients. But I would like to see also more details on whether the remaining life of these patients is having added quality, because I think this is what is very important. And last but not least, I think we have to be sure that all modern applicable treatments for including induction for the management of lung cancer, they should be very well benchmarked within the oncology group and the surgical group in order to make sure that we offer the patients the safest pathway for treatments with a curative intent. I would like again to thank you for inviting me. I think it was a lovely 2 days, and I hope we can meet each other next year, not in the same fashion, but closer.
In Milan, here in Milan,
Thank
of course.
you very much.
Thank you.
Absolutely.
Thank you, Konstantinos. It's a pleasure to introduce now for the last session a friend that is we was sharing several times working together in Barcelona. Jordi Ramon is talking today about multidisciplinary approach for orphan disease in mesothelioma and small cell lung cancer. Jordi have a prolific career working in several institutions, including Gustave Roussy, Vall d'Hebron, and now he's working in HM University Hospitals in Barcelona. Jordi, the floor is yours.
Thank you. I think that previous speaker should stop to sharing, otherwise I cannot share my slides. Okay, sorry. Can you see my slides?
Yes.
Ok. Buon pomeriggio a tutti. Vorrei ringraziare il Comitato Scientifico per il gentile invito. Thank you very much for this kind invitation. It's a real honor to stay here in this very relevant symposium. And it has been mentioned before by previous speakers, but it's true that the introduction of immune checkpoint inhibitors in advanced non-small cell lung cancer patients has really changed the treatment paradigm and also the prognosis of these patients. And today, almost 1/3 of these patients are alive at 5 years when receiving immune checkpoint inhibitors. So during the next coming minutes, I will try to evaluate whether these immune checkpoint inhibitors have had the same relevance in other thoracic malignancies like small cell lung cancer or pleural mesothelioma. Both of these thoracic malignancies are considered until today an orphan diseases because in the last 10-15 years, any significant improvement in the therapeutic approach has been reported, meaning that the prognosis of these patients has remained unchanged during all of this time period. However, it seems that exists a light at the end of the tunnel thanks to the introduction of immune checkpoints inhibitors. It's true that exists a rationale for testing immune checkpoint inhibitors in small cell lung cancer patients because this disease is clearly correlated with the smoking pattern, which might be inducing a high tumor mutational burden, a potential predictive biomarker for the efficacy of immune checkpoint inhibitors, and also because the immune system is really involved in the physiopathology of paraneoplastic syndromes related to the small cell lung cancer patients. Based on a 2 years overall survival rate of 20% at 2 years with nivolumab and pembrolizumab, coming data from the phase 1 and phase 2 clinical trials, the FDA has approved these agents as a third-line treatment in extensive disease small cell lung cancer patients. However, I have some personal concerns about this survival benefit because I do not really know if this benefit is real or just a spurious effect related to the over-selection of the patients included in these trials, and also any of these trials has a control arm. This is even more intriguing after the presentation of the results of randomized phase 3 clinical trials. As an example, the CheckMate 331 trial, which compared nivolumab versus chemotherapy in previously treated patients, or the CheckMate 451, which compared nivo-ipi-nivo versus placebo as a maintenance treatment in extensive disease. Any of these trials have reported that the immune pathway or the immune arm improved the overall survival comparing with the control arm. It might suggest perhaps that the immunotherapy as monotherapy, it's not enough for overcoming these small cell lung cancer patients. However, as it has been mentioned before, the change has been produced in the first line setting with the immunochemotherapy strategy. And today, at least 5 randomized phase 2, phase 3 clinical trials have reported that the addition of anti-PD-1 or anti-PD-L1 to the standard platinum etoposide chemotherapy in first-line setting improved the overall survival compared with chemotherapy, with a median improvement in the median overall survival of 2 months and reducing by 30% the risk of death for those patients who receive immunochemotherapy strategy. And based on the data of the phase 3 clinical trials, atezolizumab or durvalumab in combination with the chemotherapy is today the newest standard of care in the European Union. It's important to say that this immunochemotherapy strategy did not increase the toxicity profile compared with chemotherapy, and for this reason, there is a not negative impact in the quality of life for these patients who receive immunochemotherapy. However, not all is perfect, and if we compare the magnitude of benefit of the immunochemo strategy in small cell lung cancer compared with non-small cell lung cancer, we can see that the magnitude of benefit is more modest in a small cell compared with non-small cell lung cancer, suggesting perhaps that the tumor microenvironment of a small cell lung cancer tumors is more immunosuppressive, or perhaps that the anti-PD-1 or anti-PD-L1 are not the best or the most suitable strategy for this disease. Indeed, we know that today we don't have any predictive biomarker for selecting the patients who can benefit the most of the combination of chemoimmune in small cell lung cancer. Despite that this tumor has a very high tumor mutational burden, the tumor mutational burden, the cutoff, it's not relevant for defining to be used as a predictive biomarker. Similarly, in contrast to non-small cell lung cancer patients that approximately 60% of the tumors may have a PD-L1 expression, less than 10% of a small cell lung cancer has a PD-L1 expression, and this positivity do not correlate with the benefit or not of immunochemotherapy. So today, we don't have any predictive biomarker. However, we know that those patients who receive immune checkpoint inhibitors, small cell lung cancer patients who receive immune checkpoint inhibitors and develop an immune-related adverse effect has a better outcome compared with those who do not develop an immune-related adverse event. Despite this benefit in extensive disease, it has not been, for instance, translated in localized disease, and the first evidence comes from the STIMULI trial. It's a randomized phase 2 clinical trial which addressed the role of nivolumab and ipilimumab compared with placebo after chemoradiotherapy and prophylactic cranial irradiation for patients with a localized disease. The trial did not achieve the primary endpoint because there was not a benefit in progression-free survival with nivolumab and ipilimumab, nor the overall survival. I do not really know if this lack of benefit is as consequence, again, because immune checkpoints as monotherapy IO, it's not enough in a small cell, or because the treatment duration with nivo-ipi was very short in this trial. Probably the ongoing phase 3 clinical trials assessing the role of immune checkpoint inhibitors in consolidation or in combination with chemoradiotherapy will help to set up the role of immune checkpoint inhibitors in localized disease. I have previously said that today it's true the new standard of care in first-line setting in extensive disease is the combination of atezolizumab or durvalumab with chemotherapy. But today exists a lot of challenges that should be answered in the coming month, especially what are the predictive biomarkers, what is the best treatment at the time of progression, and also how to place the radiotherapy, the PCI, and consolidation radiotherapy in this new therapeutic strategy. And also, I think that it will be very important or relevant to try to evaluate the new immunotherapeutic approaches, more clever immunotherapeutic approaches for lung cancer, for small cell lung cancer, and especially I think it's very interesting those immunotherapeutic approaches that target specific antigens expressed in the small cell cancer cells. And for example, the CAR T cells targeting the DLL3, that is a protein expressed in the 60% of small cell lung cancer, or be specific immunotherapies that target also these antigens, will be very relevant in this disease. Moving to the second orphan and rare thoracic malignancies is the malignant pleural mesothelioma, with an incidence below to 20 cases per million of inhabitants, mainly in elderly population, because the time elapsed between the exposure to the main risk factor of asbestos and the development of the disease is approximately to 20 to 40 years. And also it's an orphan because despite we use platinum pemetrexed, the standard chemotherapy since 2003, the median overall survival of these patients is just 13 months, and the 5-year overall survival is below to 5%. Also in unresectable, malignant pleural mesothelioma, I think it's a personal opinion, I think it's also a surgical resistant disease. Even with a pleurectomy decortication, the median overall survival for these patients is approximately 20 to 24 months. And the 1 year and 2 years overall survival is 60 and 40%. And I think that it's very important to remember these numbers when we'll talk later about the efficacy of immune checkpoint inhibitors in unresectable malignant mesothelioma. It's true that we are waiting the results of the MARS-2 trial, which will set up the role of pleurectomy decortication in malignant pleural mesothelioma with a resectable disease. There are different pathways involved in the malignant pleural mesothelioma, and one of these pathways is also the immune checkpoint immune pathway. And based on that, it has been assessed the role that perhaps immune checkpoint inhibitors might play a role in the therapeutic strategy. It's true that the tumor mutational burden in mesothelioma is very low, but approximately 20 to 40% of malignant pleural mesothelioma might express PD-L1, and similar to other malignancies, like for example non-small cell lung cancer, PD-L1 expression in mesothelioma is a worse prognostic factor, and usually it's more expressed in sarcomatoid histological subtype. Based on this background, several phase 2 and some retrospective series has assessed the role of immune checkpoint inhibitors, anti-PD-1 or anti-PD-L1, in previously treated malignant pleural mesothelioma, and the efficacy of these immune checkpoint inhibitors mirror the efficacy of immune checkpoint inhibitors in second line in lung cancer patients, a response rate of 20% and median progression-free survival of 4 months. However, again, despite this very promising data in second line in phase 2 clinical trials, it has not been reported or endorsed in phase 3 clinical trials because the PROMISE trial, randomized phase 3 clinical trial, which compared pembrolizumab versus chemotherapy in previously treated malignant pleural mesothelioma, did not achieve to improve the median progression-free survival, the primary endpoint, nor the overall survival. However, I personally think that there still exists a room to improve the efficacy of immune checkpoint inhibitors in malignant pleural mesothelioma, probably not as a monotherapy, probably as a combination strategy. It's true that the combination of IO, anti-PD-1 or anti-PD-L1 plus anti-CTLA4 in previously treated malignant mesothelioma reported a synergies in response rate and also in median progression-free survival. And this data in phase 2 clinical trials has been clearly endorsed or corroborated in a phase 3 CheckMate 743 trial, a phase 3 clinical trial which assessed the role of nivolumab and ipilimumab in unresectable malignant pleural mesothelioma in third-line setting. Nivolumab and ipilimumab compared with platinum pemetrexed, the standard chemotherapy, improved the overall survival with a median overall survival of 18 months. Remember that chemotherapy is just 14 months. And again, 1 year and 2 year overall survival of 60% and 40%, the same numbers that I previously reported in patients with resectable malignant pleural mesothelioma treated with pleurectomy and decortication. So these patients should receive surgery or not, we can discuss later. And based on this survival benefit, the FDA has approved this strategy, nivolumab and ipilimumab, as the new standard of care after 17 years in the first line setting. It's true that the all subgroups benefit of the Nivo-EP combination, but it's important to fair to say that the benefit was more relevant, the magnitude of benefit was higher for those malignant pleural mesothelioma with a non-epithelial histology and with a PD-L1 expression. Another way to boost the efficacy of immune checkpoint inhibitors in mesothelioma is the combination similar to lung cancer with chemotherapy. And today we know the data coming from 2 single-arm phase 2 clinical trials where the combination of durvalumab and platinum pemetrexed chemotherapy, both trials have reported a very impressive median overall survival of 20 months, and again, 1 year and 2 year overall survival of 60 and 40%. And under my point of view, I think that in the coming future, this combination, the chemotherapy and immune checkpoint inhibitors will be the standard of care in the all subtypes of malignant pleural mesothelioma. For instance, exist at least 4 randomized phase 3 clinical trials in first and in second line that will help to corroborate or to support that the immunostrategy plays a role in the therapeutic strategy, either in first or in second line in malignant pleural mesothelioma. And also, I think it's important because we should await the results of the MARS-2 trial, but if the surgical procedure has a role in resectable malignant pleural mesothelioma, also exist some clinical trials that are trying to boost the efficacy of this surgery, similar to the lung cancer, introducing the immune checkpoint inhibitors in the neoadjuvant or in the adjuvant setting. As a conclusion, today we have a new standard of care with the combination of chemotherapy with atezolizumab or durvalumab as first line in extensive disease small cell lung cancer patients. But this new standard of care, and from my point of view, is challenges because the benefit is modest, despite exists at 20% of patients that could be alive at 2 years. There is no predictive biomarkers, and we don't really know how to place the potential role of radiotherapy in these patients. Again, we have a new standard of care, for instance, just in the United States, in malignant pleural mesothelioma, with a combination of nivolumab and ipilimumab. Under my point of view, with a magnitude of benefit higher in non-epithelial and probably in PD-L1 positive tumors, but probably in the coming future, the combination of durvalumab and chemotherapy will be the new standard of care. And thank you very much for your kind attention.
Thank you to Jordi for this lecture, because are really, really important and relevant also for the clinical practice, maybe in the future. A lot of work we can do into this non-orphan disease at the end of your speech. And probably it's really too late to have the occasion to do some question about this presentation, but I appreciate and I would like to thank again for this talk. So we can conclude this second day about the advanced non-small cell lung cancer and thoracic neoplasm. I would like to thank all the panelists, the presenters, the chairs, and also again the possibility to all the sponsors to give the opportunity to do this kind of virtual symposium. Is really fruitful and very important also for our clinical practice. It's the future probably, but it's the near future in order to improve the patient journey for the real practice in the next few years. So, Federico, if you want to conclude this today, because you are obviously the scientific director of this symposium, it's my pleasure to just to continue with you the few things at the end of the day.
It was my pleasure. So we are at the end of the symposium. In these 2 days, we have had the opportunity to consolidate our knowledge in the most hot points in the management of lung cancer. We had many experts from all around the world, and I thank the faculty one more. It was a pleasure to spend this time together. I thank also moderators and sponsors. Of course, moderators made the sessions more interactive and more interesting. Sponsors supported the symposium despite various difficulties due to the pandemic. So, good evening to the audience, good evening to everybody, and hopefully see you in Milan next year.
Okay.
Bye
Thank you so much. And we will see you around the world, and stay safe and resilient. Okay.
Stay safe.
Have a nice night. Bye. Bye-bye.
Bye-bye. Bye.
Bye-bye.